Right. So if you have read and understood considering a critical care scenario, kindly tell me how would you manage this patient now?
Okay, I'll start managing by the ABCDE protocol
Okay.
by seeing if there is any vomitus or blood in the mouth. I will do suction, and then I will give high flow oxygen to the patient. And for circulation, I will open to wide bore cannula, and I will also take some blood for the normal investigations like CBC, electrolytes, then ABG, along with the prothrombin time and the coagulation, um, prothrombin time and the platelet count. And after discussing with my hematologist, I will give 2 units of blood since the patient is vomiting blood. And then after close monitoring of the pulse blood pressure, and also will check the urine output, and will control the bleeding by giving pharmacological measures like octreotide or vasopressin. And
Okay.
if it is not controlled by that, we'll give tamponade, that is Minnesota tube. And if
Okay.
still it doesn't work, then we'll go for urgent endoscopy, that is endoscopic banding or injection sclerotherapy. Still, if this bleeding is not controlled, we'll go for surgical measures like portosystemic shunt or stapled esophageal um,
Right.
esophageal what you call
Can you, thank you. Can you please tell me, considering the scenario of this patient, what are the differential diagnoses that you'll keep in your mind while managing this
yeah.
patient?
Okay, this could be bleeding esophageal varices because due to portal hypertension,
Good. And
and it could be Boerhaave syndrome since the
yes.
patient is alcoholic. It could
Okay.
be also Mallory's tear or
Very good.
bleeding peptic ulcer.
Very good. Okay. Now that you have talked about portal hypertension, can you tell me the pathogenesis behind it, especially in
Yes,
patients with chronic alcoholism?
yes. Because of cirrhosis that is resulting from chronic liver disease, there
Yes.
will be liver cell damages, and there will be fibrosis and nodular regeneration.
Very
And
good.
these fibrosis obstructs the portal venous return and
Yes.
resulting in portal hypertension. And also arteriovenous shunt within the liver will also contribute to hypertension.
Can you name a few sites where this photosystemic anastomosis takes place or occurs?
Yes, it occurs at the lower esophagus, then at the upper anal canal, also
Lower
around the
esophagus. Oh,
umbilicus,
okay. In the left gastric. Okay. Then, yes,
left
please.
gastric, yes, upper anal canal, and around the umbilicus, bare area of the liver.
Yes.
This can also be retroperitoneal and very rarely in the portal ductus venosus.
Where is the site normally for this particular patient, if I may ask you?
This is at the lower esophageal region,
Yes.
and it is caused by systemic, by the azygous vein and portal system, that is the esophageal branch of the left vagus vein.
Okay. Can you please tell me who would you involve in the management of this patient?
I will involve the surgeons,
Yes.
then also involve anesthesiologist,
Yes.
then nursing staff, then
Yes.
radiologist,
Yes. And
and hematologist
yes. And
will involve um,
yes. Who take care of livers and if there is
and also the hepatic
biliary,
surgeon,
yes, hepatobiliary
hepatobiliary.
consultant or
Yes.
yes, very good. Okay, you said you'll wait and then you'll even transfuse blood. What type of blood products or the whole blood would you consider infusing into the patient or
I
giving
will
to the
give
patient?
I'll give fresh frozen plasma or fresh frozen plasma or
Platelets,
um,
okay. After
platelets
discussing it with hematologist, okay. Can
with
you please tell me
hematologist.
What are the indication for transfusing platelets?
It may be if there is hypersplenism or
Yes.
disseminated intravascular
If you can,
coagulation.
yes, if you can divide it into active bleeding and passive bleeding or afterward. So maybe you can tell me like that, or how would you classify it? Okay, tell me the way you know. You can learn the
Okay.
classification later.
Okay, ma'am. If there is hypersplenism, DIC, hemodilution, or when there is decreased level of platelets in the
Yes.
blood, then only we'll give platelets.
Okay. And
Okay.
what else would
And
you monitor or take care of?
I will monitor the prothrombin time
Yes.
to see if there is any coagulation, to see the coagulation, and also we'll check.
Can you name certain
um,
certain causes which cause or will lead to thrombocytopenia in a patient? One, liver
sorry, ma'am.
dysfunction, hypersplenism, and DIC. Okay, we knew it. Right.
Yeah.
This patient who is already alcoholic and hypertensive and also suffers from hepatitis C can also lead or can also suffer from a condition that you should keep in your mind while managing this patient. Can you tell me what?
Hepatic encephalopathy.
That can
Maybe.
result, that's a complication, but can suffer from nutritional deficiency of
Nutritional
iron.
deficiency and have macrocytic
Yes,
anemia.
that leads to, yes, anemia. And how would you manage that?
Um, uh, by giving vitamin
Okay,
B12.
when would you decide that patient should patient is if all the measures that you're taking and you still cannot manage the patient, what would you do next?
Ma'am, I'll go for surgery.
Okay. Then?
And that would involve tips or stapled esophageal. I don't
Transaction.
remember. Transaction. Yeah.
Okay. Yes. What exactly do you do in this technique?
Ma'am, we ligate the gastric and the short gastric artery, and then transecting the lower portion or distal esophagus, and then
Yes.
reanastomosing it near the cardia via
Stapling gun.
stapling gun.
Okay. And in which condition would you consider liver orthotropic liver transplant? When the condition is advanced? Okay, right. If I ask you, what are the indications of using Minnesota tube?
Minnesota tube, ma'am, or when there is when the bleeding cannot be controlled, when there is uncontrolled bleeding, or when there is no availability of the endoscopic banding or the endoscopic injection sclerotherapy. When this cannot be performed, we can use this Minnesota tube.
Or when patient does not respond to the medical therapy and even the endoscopic intervention has failed or is unavailable, then you use that. Okay, good.
Okay.
So are there any contraindication with that?
Yes, ma'am. If there is any surgery to the esophageal, in the esophageal region,
Yes.
in the lower esophagus, then we won't do it because this might cause necrosis to that region and may cause stricture as well.
Already, if there are strictures of tear or occipital tear or strictures present, or there has been a recent occipital gastric surgery, so you will not do it. So that's a big contraindication. Good.
Yes.
Right. Thanks.